This is EHJ Today in Davos, Switzerland at the Cardiology Update, and I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm talking to my colleague and Deputy Editor of our journal, Gerd Hindricks from Leipzig. Welcome, Gerd.
Privileged to be here, Tom.
So we talk about telemonitoring heart failure. Why would we need telemonitoring heart failure? What's the advantage of such a technology compared to usual care?
I mean, heart failure is one of the endemics in cardiovascular medicine, and it's simply huge, and we need to stay in control and improve the treatment, the quality of care for the patients. In regular care, we see heart failure patients maybe every 4 weeks, every 6 weeks, or once every 3 months, and we do not have sufficient information about the course the patient is taking in between. This sets the stage for application of telemonitoring of these patients. If we look to the field, there were some successes but also some disappointments in the application of different modes of telemonitoring in heart failure patients.
What sort of parameters can we measure in this manner? What vital parameters are accessible?
There have been studies performed in heart failure patients with basically two setups of technologies. One technology setup involves structured interviews. We have trained heart failure nurses that call the patient every morning, remind the patient, take your pills, what's your weight, how are you feeling, and support the patient every day by a structured interview. The second platform that has been investigated involves measurement of blood pressure and daily weight measurement. Usually there is a special setup for the blood pressure measurement apparatus and to measure the weight that automatically transmits via the internet to a central unit analyzing these data.
So blood pressure would be measured arterially or in the pulmonary circulation or both?
No, it would be measured arterially. Mm-hmm. We have technologies that are currently under intense clinical investigation that also allow pulmonary artery pressure measurement and the first and automatic transfer of the data to the physician, the CardioMEMS technology, and first data that we have seen are really encouraging. And this brings us to one of the key prerequisites that we need to successfully implement telemonitoring. Whenever the patient is involved in the generation or transmission of data, it gets difficult. Patient compliance plays a key role. For example, the TILA-HF trial that was published in New England Journal of Medicine a couple years ago was a negative trial. And if you analyze the data, you recognize that almost 50% in the intervention arm did not comply with the study protocol. So we need to consider automatic data generation, automatic data transmission, and automatic access of data by the physician.
And what about the ECG? I mean, if you have a device implanted, you should be able to transmit the ECG and detect AFib or any other more dangerous arrhythmia.
That's actually the way we went into the field in the InTime trial. The InTime trial was the first prospective multicenter randomized trial assessing the feasibility of implant-based monitoring of electrical parameters in heart failure patients.
They had an ICD implanted, and then they were randomized to telemonitoring or not?
Exactly, that's what we did. We randomized 600 and roughly 660 patients with advanced heart failure, mainly with remote myocardial infarction, so 70% ischemic heart disease, 30% non-ischemic cardiomyopathy, with a reduced ejection fraction around 25%, that received a dual-chamber ICD or a CRT ICD according to current guidelines to home monitoring support versus optimal conventional treatment of heart failure.
And what sort of data were transmitted? Mainly ECG?
Mainly ECG data. We set up a list of 9 different conditions where the device automatically triggered an event. That was onset of atrial fibrillation, that was a significant atrial fibrillation burden, that was the first episode of ventricular tachycardia, first episode of ventricular fibrillation, technical issues with the device, and also decrease in CRT delivery. 70% of the patients had a CRT-D device implanted. And once one of the triggers was met, there was an automatic chain of information activated from the patient to a central monitoring unit that was located at Heart Center Leipzig, where we centrally monitored all 660 patients, regardless whether they came from Europe or outside Europe, contacted the physician or the patient, and took adequate action in order to explore potential problems and give advice to improve therapy.
And what did you find? The
primary endpoint of the in-time study was a modified PECA score. The modified PECA score is one of the most accepted endpoints in heart failure trials. And the modified PECA score analyzes mortality, analyzes heart failure hospitalization, or analyzes during the course or at the end of the study the New York heart failure class the patient is in. Secondary endpoint involved total mortality. We analyzed cardiovascular mortality, and we also analyzed the usefulness of transmitted data in order to predict deterioration of heart failure.
And what was the result?
We saw a significant benefit in the home monitoring arm. We saw
in what sense a significant benefit?
With respect to the PECA score, we saw worsening of the condition of the patient according to PECA score in 27% of the control patients, but only 18% in the patients on home monitoring. This was, and we were surprised about that, mainly driven by a significant reduction in mortality. We had 10 deaths in the home monitoring arm as compared to 27 deaths in the optimal medical therapy arm. This is a relative reduction of total mortality by 58%. That's really huge. We were surprised to see that. Then we went into the analysis of total mortality and checked for cardiovascular mortality, and basically we had the same observations. Cardiovascular mortality reduction of cardiovascular mortality was the main driver for the PECA score and was significantly reduced in the home monitoring treated patients.
That's very exciting. Now, when we say that this works and we should implement it in clinical practice, what do you need to run this? Because if you have the information, you have to react. And in the trial, you did that out of Leipzig. But so a center who wants to implement that in clinical practice, they need staff to actually look at the data and call the patient and give it appropriate advice.
We have to set up a specific infrastructure in order to meet the needs and requirements to take the optimal benefit for the patient out of this type of therapy. And we also have to address the problems of individual practitioners or clinics to set up such an environment. So, as always, Tom, it makes sense to bundle forces. So 4, 5, 6 hospitals should combine forces, set up one monitoring center. The data will be distributed to individual doctors, no problem. But the efforts that need to be undertaken in order to let the system run can be shared by different parties. I think this is the way to go. We need to set up monitoring centers where a multitude of hospitals and individual doctors can attach their patients to.
Yeah, and we need reimbursement, right? Do you get reimbursement in Germany?
Oh, reimbursement is a difficult issue in Germany as well. The payers in the system are very reluctant in order to accept that an improved treatment quality and improved workflows and the setup of new workflows needs an adequate financing. It
may save costs eventually.
At the end, it may save costs, and we have published in European Heart Journal very recently the EURO-ECHO trial that analyzed the costs and benefits of home monitoring platform. And at the end of the day, the EURO-ECHO trial showed that despite the setup of this additional infrastructure, the costs will not increase, but the quality of treatment does increase. And at the end of the day, we will reduce the cost, because when we keep patients with heart failure stable, they will not deteriorate to the same extent. They will stay stable, and at the end of the day, they will save money.
Well, that's very exciting. Thank you very much indeed, Gerd.
My pleasure.